Alright, so now we're going to talk about immunodeficiencies. And this is when people are deficient in some part of the immune system. Okay, so we just mentioned a little bit ago that some people are IgA deficient. Well, there are numerous different possibilities of immunodeficiencies. White cells, T cells, B cells. We'll talk about all of them. But just as a general overview, we're gonna mention some of the basics. So people who are deficient in B cells, like we see here, what are they most susceptible to? B cells, think bacteria, because B cells are your main assistant when it comes to tackling bacteria with the antibodies and complement activation. So keep that in mind. And what about T cells? If someone is lacking in T cells, what are they at risk of? Remember, T cells, especially cytotoxic T cells, help you combat viruses. Okay, and so T cells more so viruses and B cells more so bacteria. There are overlaps, obviously, but in general, keep this rule of thumb in mind as we go over the following immunodeficiencies. Deficiencies in B and T cells are generally associated with what types of infections? Bacteria and viruses, respectively. Alright, so the way we're going to talk about immune deficiencies is by really a USMLE format. So I'm going to discuss a clinical scenario first, and then you're going to try to guess what disease I'm describing. So the first section that we're going to talk about is B cells, so everything that has to do with B cells. Alright, so the first one, you ready? Okay, a 6-month-old. He starts developing recurrent bacterial infections, and on physical exam, you notice that his lymph nodes are shrunken. So bacterial infections, what immune cell do you think is deficient if he has primarily bacteria causing problems? Probably B cells. So you take a look at his B cells. You see that he has a normal amount of pro-B cells, so the precursors to B cells, but a decrease in every other type of B cell. What do you think his diagnosis is? Bruton's Agammaglobulinemia, all right, and it's X-linked. So why did this happen at 6 months? Well, that's because that's about when the antibodies that were originally from his mom that were given through the placenta, that's about when they start wearing off, is at 6 months. And so this poor kid, he can't make any himself, so that's when he starts running into trouble. Other information about this disease, it involves the BTK gene, which is the TK stands for tyrosine kinase. And without this, the B cells cannot mature. But that's why he still has a normal amount of pro-B cells, just a decrease in the mature ones. So if you think about B cells, they make what? Antibodies, right? And antibodies are very important in opsonization, or facilitating macrophages with phagocytosis. So you need antibodies for that. And it's only in boys. So this is a disease of Bs. Bruton's is Bs. Think B cells deficient, BTK gene, and in boys, why boys? Because it's an X-linked disease. Next one. This poor kid. You see he's all swollen. He's in anaphylaxis right after being given blood. Let's say he was in an accident, he required a blood transfusion, and then he went into anaphylactic shock and was swelled up just like we see here. Additional information about him, you notice that his history is filled with mucosal infections. So he has a lot of gastroenteritis and sinus infections. What do you think his problem is? Selective IgA deficiency. So this is just like one of the reactions that we talked about earlier, one of the transfusion reactions. This guy, this kid, he doesn't have IgA, so when he's given blood with IgA, he has a reaction to it. The reason, why would he have mucosal infections? Well, that's because IgA is primarily secreted in your mucosa, as we saw. Remember, what does it acquire before it's secreted? That secretory component. Okay, very good. So this is the most common type of selective immunoglobulin that is low, is IgA. All right, continuing on with the B cell deficiencies. Let's say that this woman, she develops this erythematous rash on her cheeks and nose. What type of autoimmune disease do you think she could have with this rash? Well, first of all, what would this rash be called? if this is the malar rash, she could have lupus, right? Let's say she also, unfortunately, develops a type of lymphoma, too, later on in life. So she has autoimmune disease and lymphoma, and then you look at her labs, and she has a decreased amount of plasma cells as well as immunoglobulins. What is her diagnosis? She has common variable immunodeficiency. All right, and this is a unique one. So things to know about this one for your tests is that it's very common in adults. So adult immunodeficiency, think CVID. It's acquired, all right? And it has to do with B cell maturation. So it targets B cells and it prevents them from maturing normally. And just remember, too, that it's associated with these autoimmune diseases and lymphomas later on in life. All right. So now that we've wrapped up B cell deficiencies, let's now talk about T cell deficiencies. So again, what type of infections would you expect in these people? Primarily viral, right? Viral infections? Right. So first one, let's say a woman has a low threshold for contracting her muscles randomly. Every time she gets her blood pressure checked, this happens to her hand. Just a side note, what metabolic abnormality can you guess that she has? She could have low calcium or hypocalcemia. Why is this? Is calcium an intracellular or extracellular ion? It's primarily extracellular. So when you have a decreased amount of it, there is relatively an increased positivity on the inside of cells, including nerves. So, therefore, there's a lower threshold for action potentials and thus muscle contractions. Very good. Nice little review there. So, in addition to the hypocalcemia, she also has some other problems. She's got all kinds of issues. So, she has a cardiac abnormality. She has an abnormal face, abnormal appearing face. She has a thymus that is absent. Okay? Well, what matures in the thymus? T cells, right? Interesting. She has a cleft palate, and like I just said, she has hypocalcemia. You look at her chromosome, maybe do a fluorescent in situ hybridization study, FISH, and see that she has a defect on her chromosome 22. What is her diagnosis? DeGeorge syndrome, or thymic aplasia is another name for this. So this is due to, like you see here, a defect on chromosome 22. And a nice mnemonic to remember all the things associated with this disease is catch-22. Embryologically, the thymus develops from the third and fourth pharyngeal pouch, so everything else that develops from those pouches as well will be affected, including, like we just saw, her cleft palate and her face. So that's why she has facial abnormalities. All right, the next T cell deficiency is really straightforward. It'll be brief. So let's say someone presents with disseminated tuberculosis infections over their whole body, and they've had numerous viral infections. Okay? But it's particularly if they've had disseminated TB infections, what rare genetic defect could they have? Interleukin-12 receptor deficiency. So do you remember when we were talking about T cell maturation? What did interleukin-12, what role did that play in T cell maturation? Well, it actually stimulated T helper type, do you remember? Type 1 cells to mature. Remember 1 before 2, it stimulates the 1 cells. So T helper type 1 cells are very important in controlling tuberculosis infections. They stimulate macrophages with what cytokine? Interferon gamma, okay? They stimulate macrophages with interferon gamma and help macrophages degrade tuberculosis organisms. All right, the next T cell deficiency presents with abnormal faces, recurrent abscesses, retained primary teeth, increased IgE levels, and dermatologic problems, like we see here with this systemic eczema. What is the diagnosis? This is Job syndrome, or hyper IgE syndrome. And what is the underlying defect here? So it's actually a problem with T cells synthesizing interferon gamma. And what does this lead to? So first of all, why does it lead to increased IgE? So actually, interferon gamma is responsible for stimulating T cells, T helper type 1 cells, but it inhibits T helper type 2 cells. So when you don't have as much interferon gamma around, and you won't have as much inhibition of T helper type 2 cells, and thus they'll be increased in activity. And what will they go and do? What are T helper type 2 cells responsible for? They help B cells class switch to make IgE, right? Through interleukin 4. So that's why we have the increased IgE we see here. Another downstream effect is that there won't be as much chemotaxis. So actually interferon gamma is helpful in placing receptors for neutrophils to be called into and attached to in areas of infection. So it's very important in neutrophil chemotaxis. As we know, it also is important. The most important thing is it stimulates macrophages too. So you won't be able to combat infection quite as well, and that's why we get the recurrent abscesses. All right, next one. What is this cottage cheese-like substance in this poor infant's mouth? This is oral thrush due to Candida albicans fungus. So this is chronic mucocutaneous candidiasis. That's what this deficiency is. And what's it due to? Well, it's due to T cell dysfunction, just a vague T cell dysfunction on the surface particularly. So individuals will have chronic skin infections due to Candida because T cells are required for combating Candida albicans. All right, so now we're going to talk about deficiencies that involve both B cells and T cells. So this will lead to severe infections and severe problems, as we'll see in our first example. So let's say that this poor kid, he presents with recurrent viral, bacterial, fungal, and protozoal infections. Wow. On X-ray, he has a decreased thymic shadow, and on physical exam, he has absent lymph nodes. The thymus, of course, is associated with T cells. Lymph nodes, those are mainly associated with B cells. Okay, B cells make up the bulk of lymph nodes. So he's a problem with both T cells and B cells. What do you think his diagnosis is? SCID. These are the so-called bubble boys. And SCID stands for severe combined immunodeficiency. Very severe disease. So what is the underlying mechanism? Well, actually, there are potentially 3. Okay, and you can remember them with the mnemonic RAM, the R, A, and M. So the R stands for receptor, and specifically interleukin 2 receptor on T cells. So this is a very important receptor for stimulating all types of cells, because recall Th1 cells are vital in stimulating not only T cells but also B cells and macrophages. So you need this, otherwise you're going to have problems with all your immune cells. And this is the most common type of SCID, and it's X-linked recessive, which means who will be affected? Boys will. Boys will be affected by X-linked diseases. The next cause of SCID is the A, and that stands for adenosine deaminase. All right? Adenosine deaminase normally breaks down ATP and recycles it, recycles nucleotides. But if you don't have ADA, you're going to have an increase in ATP and an increase in deoxy ATP. So what's the problem with this? Well, both of these two compounds are actually inhibitory and provide negative feedback on the enzyme ribonucleotide reductase. This enzyme is very important in synthesizing and recycling nucleotides, like I just mentioned. So if you can't recycle nucleotides, you're going to have a problem, because what cells are proliferating all the time and are requiring a lot of nucleotides, a lot of DNA? Immune cells, right? Think of B cells proliferating when they're trying to respond to a pathogen. They multiply like crazy, but they won't be able to without any DNA. So that's the problem, is a decrease in DNA due to the deficiency in ADA. All right, the third cause of SCID is a problem with the MHC2 receptor on antigen-presenting cells. So this is very similar to the mechanism of not having an interleukin 2 receptor. Basically, MHC2 and interleukin 2 are responsible for communication of immune cells with one another. So if they can't communicate, then they can't work. They can't stimulate each other, and you'll have a lot of infections. All right, the next deficiency is all about A's. So it presents with ataxia, problem with walking, angiomas, and IgA deficiency. So here we see some telangiectasia, or angiomas here, in the eye, in the sclera of the eye. What do you think the diagnosis is? This is Ataxia telangiectasia, named appropriately because it presents with ataxia and telangiectasias. And if you do a laboratory study, you'd see that there's a decrease in IgA. What's the underlying defect of this disease? It's actually a problem with the ATM gene, and this is associated with DNA repair, so they can't repair DNA. All right? And as we just talked about, DNA is important for proliferating immune cells like B cells and T cells. So that's why they have problems with both their B cells and their T cells. And they also have these other deficits too. Continuing on here with the B and T cell deficiencies. So this one presents at 6 months of age. And recall what we said about 6 months? That's when infants stop receiving passive immunity from their mothers, right? That's when they're forced to make antibodies on their own, but this kid, he can't. So he's developing severe purulent infections. You look at his labs, you see that he has a dramatically increased IgM count, but a decrease in every other type of immunoglobulin. So what's his diagnosis then? Just as his labs say, he has hyper IgM syndrome. What's this due to? Well, recall, what's the first antibody made by B cells before they class switch? IgM, right? So it sounds like this B cell, or this kid's B cells, are having a problem with class switching. Well, what receptor is important for class switching? CD40 and CD40 ligand, right? So that's actually the defect of this disease is with this CD40 ligand receptor. This infant can't class switch. He'll have dramatically increased IgM, but no other type of antibody. And the thing about this is that you really do need IgG, because you recall IgG was an important opsonin for phagocytosing bacteria. What else was an opsin? C3b from the complement cascade. Okay, so he'll still have that, but he won't have IgG. He won't be able to combat bacteria quite as well. That's why he ends up with these purulent infections. All right, continuing right along. So this next kid has thrombocytopenia, low platelets, recurrent infections, and eczema. You should already be thinking of a diagnosis here. But you look at his labs and you see a decrease in IgM. What is his diagnosis? Wiskott Aldrich syndrome. And for this one, this is a progressive deletion of both B and T cells. And there's a helpful little mnemonic is tie, T-I-E. And you can think of Whiskers the cat wearing a bow tie, who drank all the milk with an M. So that's why there's a decrease in IgM. And tie for thrombocytopenia, infections, and eczema. All right, so we're done with B and T cells now. Now we're just going to discuss phagocyte dysfunction. So neutrophils, macrophages, those types of cells. And the first one is a kid or an infant who has recurrent bacterial infections, but no pus at the sites of infections. And after he was born, he had failure of his umbilical cord to separate. So this is a dead giveaway, especially on the U.S. only. If you see this, you should be thinking of something already, and that is leukocyte adhesion deficiency. So his white cells have a problem adhering to the endothelium of blood vessels and extravasating into tissue. Okay? And that receptor is CD18, or another name is leukocyte function associated antigen integrin protein. Okay? So LFA integrin protein or CD18 deficiency. Remember that for your boards because you will be asked it probably. And the dead giveaway will be that their umbilical cord does not separate because neutrophils are important in actually separating the umbilical cord. It takes the reactive oxygen species to help lyse that attachment. All right, continuing on here. The next kid presents with recurrent infections, albinism, neuropathy, and coagulopathy. So we see here an abscess. So he has recurrent abscesses. Why? What's going on here? What do you think the diagnosis is? All these random symptoms. Chediac Higashi syndrome. Well, what's the underlying defect? The underlying problem is with microtubules, and specifically a gene called the LIST gene that is responsible for microtubule function. So, when you don't have microtubules, how does that explain all these symptoms? Microtubules are vital for not only motility of cells like neutrophils and macrophages, but also for granule release. So all these macrophages won't be able to release their enzymes. That's why we get recurrent infections, and they won't be able to move with their pseudopods, so they won't be able to make it to the site of infection. What about albinism? Melanocytes require microtubules actually to transfer their melanin granules, so that's why we get a loss of pigment in the skin. And neuropathy, because nerves, they transport all their proteins using microtubules and granules, so that will be disrupted. And then coagulopathy, because platelets, recall, they release all the alpha and delta granules that contain clotting proteins like von Willebrand's factor, so that will be disrupted as well. So that explains all these symptoms, and especially the recurrent infections like we see here. All right, time for our last immunodeficiency. And this one presents with someone who has recurrent infections by catalase-positive organisms. This should be a dead giveaway, but again, if you can remember from micro, what are some catalase-positive organisms? Things like Staph aureus, Pseudomonas, and Klebsiella. Okay, so what's the diagnosis here? Chronic granulomatous disease. And what's the underlying defect? It's a problem with NADPH oxidase. It's X-linked recessive, so another X-linked disease, which means only boys are affected. But NADPH oxidase, what does that normally do? Well, it actually forms free radicals from oxygen. And particularly, and specifically, superoxide free radical. So free radicals, as we said before, they're very dangerous substances. They'll take out anything in sight, your cells or pathogens. But inflammatory cells use them and synthesize them to kill pathogens. Superoxide eventually is converted into peroxide. And then down the line, it will make basically bleach, or the hypochlorite ion that is very lethal to pathogens. So what happens in this disease is that if you can't form this superoxide free radical, then you won't have any of these downstream compounds to fight off infections. But you will still have some peroxide around, just it'll be decreased, significantly decreased. So why are catalase organisms so dangerous to these people? Because catalase, what does that enzyme do? It actually breaks down peroxide. So what little peroxide these individuals have left will be completely used up by the catalase-positive organisms, and they will be able to take over and cause all these abscesses in these individuals.